have a million other questions, but I think we would move on to Juan Dari Ortigoza Escobar, our next speaker, who is from Barcelona, who's going to be telling us about the severity puzzle, unlocking insights into GNAO1 related disorders.
Okay, good morning to everyone, and thank you for the invitation. I will skip some slide because we already learned about what is GNO1 is. I will present with the permission of the families some videos or photos, so it's not allowed to record this. We will talk about the GNO1 definition and phenotype. We will also talk about brief about the severity score, the mild forms, the dyskinetic crisis, and also a project of the excitatory inhibitory ratio measured by the video EEG, and also about the mortality. So we have heard that this GNO1 disorder is characterized by a broad spectrum of epilepsy, intellectual disability, movement disorder, including this very interesting phenomena called dyskinetic crisis, hypotonia, and also gastrostomy. This disorder was described in 2013 and is an ultra-rare disorder. Many of the data you will see here is of the article of Science Gonzalez that compile all the published cases until last year. So to understand what a GNL1 does, I find this cartoon very helpful. You can see here that there are receptors that, for example, for neurotransmitter dopamine, that are coupled with the G protein. The G protein is a heterotrimeric protein with alpha, beta, and gamma subunit. You will see in red what are measured in the laboratory, and I will show you some experiment made by Dr. Martemianov about this, and a score that resulted from that work. So the first part is the GPR signaling, and this is impaired in all patients. So this cannot help, is not helpful to differentiate mild to severe form. Then we have the tremor formation, and I will show you in a few minutes that this is the most important measure to differentiate mild to severe or moderate phenotype. And also there is a receptor interaction between the alpha subunit and another receptor. And all this can be measured by bioluminescence resonance energy transfer assays. So we have heard that patients have epilepsy. Erika Xin talked about that, about 53%. But also a 30% of these patients can have other type of seizure, not including developmental and epileptic encephalopathy. Around 82% of these patients have movement disorder. They can have all type of movement disorder and also this very interesting phenomena called dyskinetic crisis. And also, as Amy has explained, hypotonia is a very important component of this disorder because that leads to the impair of the gross motor function, leading to developmental delay, and also these children have apraxia of speech or language delay. So for what is coming with the new therapeutics and everything, I think that severity score is of paramount significance because that can help to categorize this patient, also to monitor treatment response, and also to enable a more personalized approach. So in help with all the Spanish patient and also with the lab of Dr. Martemianov, we have developed, I will show you, a severity score for this disorder based on the assessment of 16 patients during 3 years. You will see there the characteristic. I will skip this. So in this severity score, we include 5 aspects of this disorder that we consider are the most relevant, including epilepsy, movement disorder, the gross motor function, language, and also the use of gastrostomy. When we were doing this or developing this severity score, we know that epilepsy and movement disorder are need more items or sub-items to assess, including, for example, frequency of seizure, the intensity of duration, and the damage that can cause to the patient, and also the use of anti-seizure medication. And all this work is also made by Hannah Dominguez Carral, which is an epileptologist and in our center. So we assigned 3 points to the epilepsy, 3 points to the movement disorder, 4 to the gross motor function, 2 to language, and 1 to feeding. And this is the final score that is very easy to apply in the consultation, the outpatient consultation, because you can have the score done with 5 or 6 questions. So I will show you a video of patient to show you this broad spectrum. You will see here a patient with a mild phenotype. You can see that he can walk. He has a generalized dystonia. He can speak some words. This is a moderate phenotype. She is now with DBS because she has a status dyskineticus last year, and this is a severe phenotype with severe hypotonia, dyskinetic crisis also on DBS, and some seizures. So I will present here the work of Kirill and Grant Lutland. So they analyzed these 4 measures in the lab for all the mutation we have in our cohort. As I told you, the GPR signaling in the graph D is affected in all patients, and you can see that the tremor formation, the one that are marked with the red arrows, are presented in the patient with this more moderate or severe phenotype. So this can help us to differentiate between the severity of the patient. And also, when we perform the correlation on the clinical score and the tremor formation, we find a correlation between these 2 measures. But you can see here in this graphic that every mutation is different because it can affect in a different weight of any of these 4 measures. So in summary, we saw that each variant or mutation has a unique profile on clinical and functional phenotype, that the severity score correlate with this tremor formation, and we get a nice severity score, but we know that we need to validate this in a larger cohort. For that, we have already started a validation program that it will include the patient of the project that Giovanna talked, and also we get to get 23 now other collaborators to help us with their patient to validate this cohort. And I will show you here the data we have of this severity score around 3 years. And what we see in this graphic is that a patient with mild, marked in green, moderate in yellow, and severe in red, that not usually that not grows from one type to other. So we think it's a good measure, and we think if when the therapy comes, we can see if it is work. We can see the variation to moving from, for example, an intermediate to a mild phenotype, or something like that. So we are also very interested in describing this mild phenotype. This is a work we have done with 2 patients, one from our Spanish cohort and one from the Italian, from Italy. And you will see a video of this patient because there are very interesting and very mild cases with one of the patients only have a mild dystonia in one feet, with some seizure, but not, you can see here the seizures. He's well controlled with valproic acid, and the other patient is more or less the same, but with different mutation. And you will see here also a video of this patient. He has autism spectrum disorder, but is doing well at school. and is well controlled with valproic acid, and you can see the left too with this mild dystonia, and that's all the movement disorder he have. So when we analyze, or Kirill analyzed this, also we were very happy that the trimer formation was not significantly different from the wild type, showing once again that this measure can help us to differentiate mild to more severe phenotypes. But we were not the first one to describe mild phenotype. There are two other articles describing this. One is from Dr. Wirth, that he collected 24 patients. Some of them have an adolescent or adult onset dystonia, and around half of them also have some mild or intellectual disability. And you can see here videos from his cohort showing these mild phenotypes of adolescent and also adult patient. And also there is a very interesting case from the group of Galossi and Leusi and Martinelli that studied this 8-year-old boy. You will see the video also with a very mild GNAO1 phenotype. And they also performed some very nice functional study showing the haploinsufficiency of the gene. So one very interesting aspect that while we are waiting for treatment or gene therapy is that children are suffering from this very severe episode of this kinetic crisis and leading finally in some case to die. So we were very interested to describe the definition of this kinetic crisis, to describe the management, the triggers, and we were also surprised that before this effort, in literature there were at least 22 terms in English to describe this kinetic crisis. So we don't have the right name until this work, and you will see here a video of patients from Italy, France, and Spain, and France having this kinetic crisis. So this is now published and available for everyone who wants to read it. And in this work with 13 experts. Review 19 statement about the dyskinetic crisis, and we ended up to the definition of the phenomena and also this very nice management table. But we also are aware that we probably don't know a lot of the home management and the patient and caregiver point of view. For that, we are launching a survey. I will show you in a minute to know more about this aspect. So also another thing that we get into account is that not all drugs, for example, chloral hydrate is not available in Italy or France, and dexmedetomidine is only used in the United States but not usually while in Europe. So we see some difference of also in the management of the patient. So we to learn more about this kinetic crisis, we are launching this survey that will be available next week. It will be available in English, Spanish, French, Italy, and German. And is going to be about to explore the impact of this kinetic crisis. Also, I will show you some preliminary result of work we are doing with the help of the group of Netherlands that are helping us to analyze the video EEG. Video EEG are usually used in GNAO1 patient either for the diagnosis of epilepsy or the monitoring of EEG abnormalities. So in this work, we want to explore the excitatory inhibitory radio as a biomarker, another biomarker that can help us to understand more about the disorder. So in this work, we compare 12 GNAO1 patients with 13 A-matched control, And or that group analyzed these 4 categories: absolute power, relative power, the trend-set fluctuation analysis, and the functional excitatory inhibitory ratio of the EEG. And they found that GNAO1 patients have a higher delta absolute power than compared to control. Delta is opposed to alpha, so they have a higher delta but a lower alpha. And we found some correlation with the epilepsy severity and also with the gross motor function with this, and that was expected because a patient with a developmental epileptic encephalopathy is supposedly to have a more higher delta than a less affected GNO1 patient, and we have correlated. So this is going to be talk about more it, but I think in the future we are going to classify the patient not only by this severity score, but also by the response to sync. I will skip this. And then in the meeting of June in Rome last year, Jane Yu is a mother of a GNO1 Italian patient. She keep the question because the parent also usually have some difficulties in understanding and accepting in some cases the deep brain stimulation. So to study more about this decision making of deep brain stimulation in GNO1, we also are going to perform a survey that is going also to be available next week. And also our patients are getting older. We have some patients that 2 patients that are now going to the adult neurology field. So at least in our country, it's imperative to make a good plan for transition. And for that, we want to study more about this with patient interview or adult patient, and also we are planning to do a consensus with some expert, and we are now doing some ethic committee paperwork and planning to recruit a patient and contact expert for October this year. And also I want to announce this because the Family Now Research Grant 2024 from the Italy Family Association is going to fund this biomarker project that is based on cell-free RNA. And in this project, we are going to, we already have the sample collected of 20 Spanish patients and 40 control, and we are going to analyze to see if there is a difference between, as Giovanna said, if we can find some biomarker that can also differentiate mild to severe form. I move to the conclusion, just to say that as I showed you, patients with GNAO1 show this clinical heterogeneity with mild or more dystonic phenotype, and other with a more severe and including this kinetic crisis. That biological factors such as the tremor formation are associated with the GNAO1 severity, and that patients are experiencing this mortality during the context of this kinetic crisis. And also, as I promised my patient Maria, she published this book. It's a book about the GNAO1 experience. It's a very nice book because the key message of this book is that you are not alone, and there are your family and your friends that can help us in your way through this disorder. And also, I want to thank all the GNAO1 Spanish Association with all the patients and the parents, all our study group, the Spanish one, and the dyskinetic, and also our international collaborator, and also the group of Kirill Martemianov and the group of Likenhager that are studying the video EEG. So thank you very much.
Well, Well, that was an incredibly packed presentation with a huge amount of data. I imagine that there may be some families wondering how they get that book. Is there a way that that can be purchased?
I think I have the only copy in the United States
Oh,
now.
no.
But I think you can talk with the family association because this can be translated very easy and can be print, and also can be to get some funding for some project. It's a very nice book. When I get this book at home, there were some tears of other person that read it. So it's even when you are not in the field, it's a very touching book.
Okay, so right now it's an ultra rare
Yes.
edition. Yes. Anybody have any questions? Yes.
Lola.
Just have a question as to in the severity scale, do you find that the motor severity, epilepsy, and cognitive severity track together all the time, or do you see discrepancies there?
We have analyzed some data, and the only correlation we found now is that dystonia worsen with age, but it's not related to the severity score. Maybe it's related to contractures and other things. But usually, people, children who are in the severe group, they are there because they cannot speak. They are very severely motor impaired, and they have both epilepsy and movement disorders, including this kinetic crisis. So usually, it's a pack of having everything in the severe part. Yeah.
I just want to know, how do we get the surveys? Like, are you gonna let the
we are going
associations
to
know?
we are going to pass a link, because it's done by the ERN R&D, which is the European Reference Network for Rare Neurological Disease. They put this in a secure platform, which is EU survey, and we will get a link, and you can have that link. We are going to distribute through patient associations.
One question from the internet is, will the DBS questionnaire be available for patients and families outside of Spain?
Yeah. We will try to reach as much as we can. Yeah.
Any other questions?
One last question.
Thanks for the presentation. Short question. Sorry for my ignorance, and if I missed it, maybe the cell-free RNA proposal you got granted. What is the hypothesis about the cell-free RNAs? What are you looking for actually? Is it like?
Well, we are doing what Giovanna called we don't know what we are going to find. Okay, so in this it's a very interesting project, because in the cell-free RNA we can study around a lot of RNA. And we can study where this RNA came from the tissue. We can do ontology pathway also, and helpfully we are going to find one or two that are going to be biomarkers. See, we have done this before in PMM2. It's a glycosylation disorder. So we have done the same, and we have found one biomarker for that disorder. So hopefully we are going to replicate that in GNAO1.
All right, well, thank you again to Dr. Ortigoza, and it looks like we are on break till 10:40. So we'll see everyone back then. Thank you to all our morning speakers.
Thank you.
For those in the room, refreshments in the back alongside some coffee. We'll be back at 10:40. Thanks.